Welcome everybody to the 9th installment of the Clinical Best Practices webinar series. And today's webinar is titled Cancer Screening and Cancer Care. It'll be delivered by me. I am Dr. Geoffrey Calvert. My title is the Associate Director for Clinical Quality. I'm a physician, board certified in internal medicine and occupational medicine. And I work for the World Trade Center Health Program, which is part of NIOSH, and that's part of the Centers for Disease Control and Prevention. So again, welcome. So we have some disclaimers. One is that the views expressed in this webinar are mine alone, don't necessarily represent the official position of NIOSH or CDC. Any of the trade names, commercial practices, or organizations that I mentioned do not mean endorsement by CDC NIOSH. And citations to websites external to CDC NIOSH do not constitute their endorsement, and we are not responsible for the content of those websites. And we do have one disclosure. One of our joint planners, joint providers, wishes to disclose that he attended some promotional programs hosted by some pharmaceutical companies, and those financial relationships have been mitigated. This presentation is based on the following paper, just like all of the webinars in this series. They're all based on papers that we published as part of this webinar or as part of the best practices series. So it's a series of 13 papers. And so we'll be doing webinars on all 13. So as I mentioned at the beginning, this is the 9th. And if you missed any of the first 8, those recordings are available. You could just Google NIOSH, Best Practices, World Trade Center to find those recordings. And continuing education credits are available for all of the recordings. And I should mention this webinar is also being recorded. So it'll be available in the future. I want to acknowledge various people who assisted with developing the series of articles as well as the webinars. So we have a clinical care work group consisting of the individuals listed at the top of the slide. We also have a planning committee for the webinar series consisting of people more in the middle of the slide. I want to acknowledge the reviewers of an earlier version of the paper that this presentation is based on. And then webinar assistance is being provided by Kiana Harper, who organized the webinar, and Ann Riddle, who will be monitoring the Q&A window and asking me the questions at the end of the webinar. And then the joint providers that I also mentioned earlier. So we're going to start off with a poll question. And so Kiana, can you launch the poll? So the question is, the World Trade Center covers screening tests for cancer at all of the following sites except one. So which of these sites do we not cover screening tests? And so we're talking about screening here. We're not talking about diagnostic workup. This is just screening for asymptomatic people. So which of these cancers do we not cover screening for? So we'll give you a few moments to make your selection. It's just one of those cancers. Okay, so most of the people were correct. So the correct answer is thyroid cancer. That cancer is not, screening for that cancer is not covered by the program. And we will discuss why in this presentation. So stay tuned. Outline of the talk. So we'll talk about cancer in the program. We'll talk about cancer screening in general. Then we'll talk about those 4 cancers that we do cover screening for. Then we'll briefly talk about cancer diagnostics and treatment. So that's basically just 1 or 2 slides, and then we'll have a conclusion. So cancer in the program. So why are we even having this webinar? So cancer in the program, as well as in the country, is an important problem. So cancer is the 2nd leading cause of death in the US. And also many people in the program are certified for cancer, meaning that we provide no cost treatment for their cancer. So among people who are certified, this is among people who are certified, 46% of them are certified for cancer. And this is a list of the conditions that we cover in our program. And you'll see in the upper left, we cover all invasive cancers. And then in the box in the lower right, you'll see that we began covering cancers in 2012. So we didn't begin covering cancers when the program started. That coverage of cancer, and that's most cancers, was in 2012. We began covering prostate cancer in 2013. And then when we added uterine cancer in 2023, we do cover all cancers now in the program. And you can see here that cancer is the second most commonly certified condition in the program. And I think one thing that at least jumps out to me is that the number of responders and survivors who are certified for cancer is roughly equal. But you need to keep in mind that there's almost twice as many responders enrolled in the program compared to survivors. So survivors are actually overrepresented in terms of proportions who are certified. Why that is, I'm not sure. So how do we identify cancers that might be related to 9/11 exposures? So typically the best studies to assess that are studies that use statewide cancer registries. There's cancer registries in operation in all 50 states. These are statewide cancer registries. Those registries capture nearly all the cancers diagnosed in that state. The exception is non-melanoma skin cancer. Those are not tracked by the cancer registries. And so findings from those cancer registry linkages have been reported. So what happens is the cohort of 9/11 exposed persons is sent to the cancer registry to do a linkage to identify which of those members has cancer. And then you could look at whether or not the numbers are above what you would expect. And so those linkages and the reports from the linkages have been published for FDNY responders, for general responder cohort members, for the World Trade Center registry responders and survivors, as well as there is a combined responder cohort that consists of basically all of the responders who were involved in the 9/11 response, including FDNY, general responder, and World Trade Center health registry. I guess it doesn't include Shanksville or the Pentagon responders, at least not yet. And so when you look at all that evidence, the strongest evidence for an association with 9/11 exposures is for these four cancers: prostate, thyroid, tonsil, and melanoma. And interestingly, we don't cover screening for those cancers. And again, we'll explain why. So this is a complicated slide, and it's the most complicated slide in this presentation. I apologize for that. It's a figure that's taken from the paper that reports the cancer findings in that combined responder cohort. And it provides the findings for all cancers combined, as well as those four cancers that have been found to have an increased risk with 9/11 exposures. And it provides findings for the standardized incidence ratio, which is basically a fancy word for a simple ratio of the observed number of cancers divided by the expected number of cancers. And if that ratio is 1, that means there's no increased risk. If that ratio is greater than 1, that suggests there might be an increased risk. And then if you have a confidence interval, which in this figure on the right, you'll see these horizontal lines. So that horizontal line represents the confidence interval. The dot in the middle of the line, that's the standardized incidence ratio estimate. And if the left side, the left boundary of that line does not cross that 1, that vertical line where we have 1, if that doesn't cross that line, that means that estimate is statistically significantly elevated. So it's unlikely due to chance in that instance. And you can see here, I've got the risk estimates circled for the people who arrived at the World Trade Center site on 9/11. So considered to be among the most highly exposed responders. And you can see for all of them, the SIR, standardized incidence ratio, is significantly elevated. Also, there's a item for worked on the World Trade Center pile. And if you look, I don't have those highlighted, but if you look at those also, they are all statistically significantly elevated. And I should mention the comparison group for these analyses was the estimates from the New York State population. So again, these cancers are considered elevated, but we don't cover screening for those, and I'll be explaining why we don't cover screening for those cancers. So we're going to talk now about general cancer screening. So what is it? So the purpose of general cancer screening is to detect cancers in an early stage in asymptomatic patients in order to reduce morbidity and mortality. So the key word here is asymptomatic. So if a person has symptoms of the cancer, that's not screening, that would be a diagnostic. They would need a diagnostic workup. So screening is only conducted on people who are asymptomatic. The benefits are that early detection can improve treatment outcomes, but you have to keep in mind that all cancer screening also comes with harms. And the harms are listed here on the slide. And you only want to do cancer screening where the benefits exceed the harms. So for those 4 cancers that there's an elevated risk for in the program, determinations have been made that the harms and benefits, the benefits just don't exceed the harms, or there's very little benefit compared to the amount of harm of screening for those cancers. So the harms include false positive and false negative results. False positive meaning that the screening test detected something that looked like cancer, but after workup, it was determined not to be cancer. False negatives are where the person gets a falsely told that there's no cancer present, when in fact the patient did have a cancer. So that's false negative. There's issues of overdiagnosis. So what is overdiagnosis? So overdiagnosis, those are cancers that are detected that would never have threatened the person's health, or never would have been detected during the patient's lifetime if not for the screening. So the issue is with an overdiagnosed cancer, when you detect a cancer on screening, you don't know if it's one of these overdiagnosed cancers or if it's a truly cancer that's going to threaten that person's health. So you have to aggressively treat basically every cancer that you identify with screening. So that could be potentially a problem. Other harms are just the anxiety, distress, psychological responses. For example, when you're told that you've got a positive result on your screening test. There's also issues with pain and discomfort. So for example, my mother never, maybe she may have gotten one mammography, but after that said, these are too painful, I'm not going to do it. And then later down the road, she was diagnosed with stage 4 breast cancer. So I wonder if she would have been getting the mammograms, could they have detected it earlier? And then finally, there's the potential for radiation exposure with some of the screening tests that we'll be talking about today. So the radiation exposures are somewhat low, but still they're something to keep in mind. They're not entirely trivial. So USPSTF and cancer screening. So what is the USPSTF, the U.S. Preventive Services Task Force? So they make evidence-based recommendations for preventive services, including screenings, behavioral counseling, preventive medications. They're a volunteer group. They are funded by the Agency for research on quality, AQPR, I think it is. And so it's a part of the U.S. Preventative Services, or the U.S. Health and Human Services. And so they make recommendations, and one of the things that they look at is screening for cancer. So based on their reviews, they've come up with recommendations that screening should happen for breast, cervical, colorectal, and lung cancer. And for each of those cancers, they've assigned either a grade A or a grade B. So those are, grade A is where there's a high certainty that the net benefit is substantial. So again, they looked at the benefits, looked at the harms, and determined that the benefits were substantial compared to the harms. For a grade B, there's a high certainty that the net benefit is moderate, or there's a moderate certainty that the net benefit is moderate to substantial. So again, also with these recommendations, patients have to meet certain criteria. And again, they have to be asymptomatic, no signs or symptoms of the cancer. So in our program, we cover screening for all World Trade Center Health Program members except FDNY family members. But we only cover screenings that are assigned an A or a B grade by USPSTF. And we also, members need to meet the recommendations, the criteria for screening from the task force, including age and risk factors, for example, smoking history. And also the time interval between screenings has to comply with the recommendation from the task force. And screening is just one step to improve cancer outcomes. So in addition to access to screening facilities with up-to-date technology, it's also important that if an abnormal finding is identified, that prompt diagnostic evaluations are undertaken and that there's access to high-quality definitive treatment in a timely fashion. So we're going to talk about each of those 4 types of cancer screening that are recommended by the task force. First being breast cancer. So a little bit of background about breast cancer. It's the most common cancer diagnosed in women, but the second leading cause of cancer death in women. So in women, lung cancer, both in men and women, lung cancer is the most common cause of cancer death. Median age of breast cancer diagnosis is 63 years. Median age of breast cancer death is 69. That's actually the age that my mother died of breast cancer. So on the right, you can see cancer incidence, and the line at the top, kind of the purplish line, shows incidence from the year 1975 to the year 2020. And you can see that almost from the 1970s, there has been an increasing trend in incidence of breast cancer. And I think that's right around the time when breast cancer screening commenced. So that might be responsible for some of the increase in breast cancer incidence. So just increased detection of breast cancers. This slide shows breast cancer distribution or stage at time of diagnosis, showing the data for all races in red, data for whites in green, and data for Black women in blue. So on the left is the cancer stage at diagnosis, and on the right, it's the survival based on the stage of the cancer at the time of diagnosis. And you can see that the outcomes are worse for Black women, both in terms of they're being diagnosed at later stages, and whatever stage they're diagnosed at, their survival is lower. And so the reasons proposed by the authors of this paper, Siegel et al., were that this is likely largely due to long-standing wealth disparities. And so when you have wealth disparity, that leads to differences in exposure to risk factors, as well as reduction in access to cancer prevention activities, less likely to get early diagnosis and less likely to get early treatment. And these wealth disparities likely are related to just hundreds of years of racial discrimination, segregation, leading to differences, impacts on treatment in terms of criminal justice, also with employment opportunities, educational opportunities, housing opportunities. So all of these contributing to the worst outcomes in the Black women. So looking at cancer mortality, and breast cancer is the pink line, you can see that beginning in around 1990, breast cancer mortality has been dropping up until 1990. It looks relatively flat. So again, as I mentioned, the breast cancer screening commenced in around, I think the 80s at some point. So this suggests that breast cancer screening, probably as well as improved treatments for breast cancer, are responsible for this reduction in breast cancer mortality. So this is what you want to look for with cancer screening. You want to, hopefully your cancer screening is leading to earlier detection of these cancers, and as a result, they're being treated more effectively and not causing a person to die of that cancer. So the task force recommendation for breast cancer screening, and this is like breaking news. It just came out a few weeks ago. These new guidelines are that women should be screened biannually every 2 years if they're the age 40 to 74 years. The last time these recommendations were updated were 2016. And so in addition to mammography, the task force now also recommends digital breast tomosynthesis. Those are the two types of breast cancer screening methods that are recommended. It should be mentioned that digital mammography has now essentially replaced film mammography as the primary method for breast cancer screening in the US, but maybe DPT will overtake that. And it's recommended if you do DPT that you also do digital mammography. So the differences between 2016 and 2024 is the age range difference. So before, screening was recommended to commence at age 50. Now screening is recommended to commence at age 40 in women. And then I mentioned the adding of the DPT, digital breast tomosynthesis. What didn't change is USPSTF still recommends biannual screening. They looked at annual screening. They just weren't convinced that the benefits exceeded the risks. So when you do annual screening, among other issues, is you get 50% more false positives and 50% more overdiagnoses. And so just they felt that the risk-benefit ratio just wasn't compelling enough to recommend annual screening. And they don't recommend breast ultrasound or MRI for screening regardless of breast density. And that's for women who have no abnormalities on DPT or mammography. So of course, if you have abnormalities on screening, then you would go for diagnostic workup, which could include ultrasound or MRI. So a few words about DPT. Again, it's a new USPSTF recommended primary cancer screening method. It's also called 3D mammography. So it acquires images from multiple angles. The issue with 2D or your typical digital mammography is you have overlying tissues, which sometimes you might have a cancer, and the 2D mammography, the digital mammography, can't detect it. But with a 3D image, sometimes you can detect those tumors. So it's considered with DBT, you've got fewer false positives, and you've got a better. It seems like they're more likely to detect tumors with DBT compared to digital mammography. But I should mention that, again, if women get DBT, they should also get a mammography at the same time, because you can even detect more cancers if you combine both of those tests. Which one issue is radiation exposure is 20 to 30% higher with DBT compared to mammography. And if you combine mammography with DBT, you're basically doubling radiation exposure compared to doing mammography alone. And a mammogram is equivalent to about 4 chest x-rays, or I think it's maybe like the amount of background radiation that you would get maybe in a month or two. A normal person would get in a month or two with background radiation. So I also wanted to talk a little bit about dense breasts. So this is basically a normal variant. Almost 50% of women have dense breasts. Beginning in September of this year, FDA is going to mandate that US screening facilities inform women about their breast density. And some states also additionally require a statement recommending that women discuss supplemental screening with ultrasound or MRI due to dense breasts. But again, the task force looked at the evidence and did not recommend screening with ultrasound or MRI for women with dense breasts. Again, unless an abnormality is found on mammography or DPT, but in the absence of an abnormality on mammography or DPT, there's not a recommendation to do ultrasound or MRI in women with dense breasts. Again, the risk-benefit ratio just isn't ideal. So in terms of compliance, there's a Healthy People 2030 recommendation, and Healthy People 2030 comes from, again, the Department of Health and Human Services. They recommend that 80% of eligible women be up to date with breast cancer screening. And in reality, looking at data from the National Health Interview Survey, which is a nationally representative survey, they find that 76% of women are up to date with breast cancer screening. So not quite, we haven't quite hit the goal, but pretty close. And a recent paper from the CDC identified that women with increased numbers of health-related social needs were less likely to be screened. So again, we were talking about earlier about just the longstanding wealth disparities. So that's kind of related to that. And this is a graphic from that recent CDC article. And again, a lot of these health-related social needs leading to fewer mammograms are related to wealth. For example, cost for access to care is a concern for some people, lack of transportation, women who are receiving food stamps, women who have lost work or have reduced hours of work. So moving on to cervical cancer screening. So one of the success stories has to do with cervical cancer and the vaccine for human papillomavirus, which was introduced in 2006, approved by FDA in 2006 for women aged females aged 9 to 26 years. And these women are now in their 20s. And you can see in this figure on the right, what is suspected to be the impact of that vaccine. If you look at the graph, on the x-axis is the calendar year, and beginning in around 2011, 2012, there's this dramatic drop in cervical cancer incidence. And it's thought that the use of the vaccine has contributed to that sharp drop. Because of the vaccine, the incidence of human papillomavirus has dropped, and about 97% of precancerous lesions for cervical cancer have HPV in them. So there's been, a pretty substantial impact from this human papillomavirus vaccine. And I think right now about 70, almost 80% of women have had at least one, or women who are females in that age range of 9 to 26 years have gotten at least one dose of the vaccine. And maybe about 65% have gotten the whole series of vaccines, which I think is 2 to 3 shots. The median age of cervical cancer diagnosis is 50. Median age at cervical cancer death is 58 years. So the task force recommendations for screening for cervical cancer depends on the age of the woman. So women who are aged 21 to 29 years have one option, which is collecting cervical cells and doing cervical cytology alone every 3 years. And then the options expand for women once they reach age 30 till age 65. They can choose from one of 3 options. So one being the cervical cytology alone every 3 years. They can do the high-risk human papillomavirus testing, alone every 5 years, which because 97% of precancers are HPV positive, that's really all you need. But if you've already collected the cervical cells, then the other third option is to do both the HR HPV testing in combination with cervical cytology, with basically the pap smear, which they call co-testing. Again, doing that every 5 years. And the task force assigns this an A recommendation, so net benefit is substantial. Another thing to keep in mind with cervical cancer screening is that it can actually prevent cancer. So when you detect the precancerous cervical lesions and remove those lesions, you're actually preventing those lesions from turning into cancer. And so in a population that's not screened, about 5% of that unscreened population over their lifetime will develop cervical cancer. But with effective screening and treatment, cervical in treatment of the cervical precancers, the lifetime risk of developing cervical cancer is down to less than 0.5%. So a whole order of magnitude reduction in the development of cancer through cervical cancer screening. So in terms of how successful are we, is the country in women getting screened? So the goal again for Healthy People 2030 is 79% of eligible females getting screened. And in 2021, the data again from the National Health Interview Survey, National Representative Survey, found again we still haven't reached that goal. We're at 74%, so still a little more work to do, but not too bad. And then what about if you do have screening and the results are abnormal on cervical cancer screening? There are recommendations for when the woman should undergo follow-up, and it's based on calculating their risk based on their current screening results as well as their previous history. In the calculation of those risks, we're estimated using prospective data from large cohorts. And so the clinician can go to either use an app or go to this website from the American Society for Colposcopy and Cervical Pathology. And basically what you're doing is looking at what's the risk of CIN 3+, cervical intraepithelial neoplasia grade 3 or more severe diagnosis. And so this chart, I'm not going to have time to go into it in detail, but you can do that calculation and then determine how soon or what type of follow-up is needed for these women. When do they need to be screened again, or do they need a colposcopy? And again, you can go to this website from the American Society for Colposcopy and Cervical Pathology for that information. But when you get to this point, yeah, this is diagnostic, this is not screening. So moving on now to cancers that involve both men and women, or screening that is recommended for both men and women. So we're going to now talk about lung cancer screening. So lung cancer is the second most commonly diagnosed cancer in both men and women, but it's and breast cancer is the most common, as we talked about, in women. Prostate cancer is the most common cancer in men, but lung cancer is the leading cause of death in both men and women. And the median age of lung cancer diagnosis is 71 years. And so you saw the chart on the bottom before for females when we were talking about breast cancer. So for lung cancer, the red line shows the trend in cancer mortality going back to 1930. And you could see, at least in men, the trend for cancer mortality or lung cancer mortality began to drop in 1990. The drop came later for women. So it was more like around 2000 when we started to see the drop, 2000, 2005. What's responsible for that drop? Obviously, reductions in cigarette smoking, maybe also some improvements in lung cancer treatment. Screening probably hasn't played a huge role, and we'll explain why, because just the penetration of screening is so low in the population. So the task force recommends annual screening with low-dose computed tomography for those who meet the criteria that I've got listed here. So the criteria are patients have to be aged 50 to 80 years. They have to have a 20-pack year or more smoking history. They have to either be a current smoker or have quit within the past 15 years. Again, like all screening, they have to be asymptomatic. Also, there has to be an absence of comorbid conditions that would substantially limit life expectancy. So you don't want to do screening on patients who really couldn't undertake treatment if the lung cancer were detected. And then also it's recommended that shared decision-making occur and that the patient agrees to screening after they've undergone shared decision-making. So the benefits, like for all screening, it reduces the benefits of lung cancer screening, reduce lung cancer mortality as well as all-cause mortality, but the risks are very substantial. False positive findings, so there's a lot of pulmonary nodules that get detected that are not cancer, but require workup. There's the potential for radiation exposure. There's the potential, and radiation exposure is can vary depending on the machine used for the low-dose CT, but it can be as much as what one low-dose CT could be as much as the background radiation that a normal person would get in a full year. Overdiagnosis, again, you could detect lung cancers that would never threaten the patient's health or would never have been detected, but for the screening. There's also incidental findings, which some people find is a benefit. Other people would prefer not to know these incidental findings. So these are findings unrelated to cancer, but you see things on the CT scan that require workup, whether it be some other type of lung issue, vascular issue, cardiac issue. And then there's the complications arising from invasive procedures. So when you find an abnormality on the low-dose CT, the procedures to follow those up, to work them up, can be pretty invasive and can lead to complications. So getting back to shared decision-making, so this is important because there are differences in individuals in terms of how they balance benefits versus harms. Some people place more emphasis on the benefits, others are more concerned about the harms. So by doing shared decision-making, you enable the values and preferences of that informed patient to be elicited, to be obtained, and then incorporated into the decision-making process. So this adheres to the principle of respect for patient autonomy. And the thing to keep in mind is it doesn't have to be the physician that does the shared decision-making. It could be other people in the clinic who could do that shared decision-making. So it could be nurses, psychologists, social workers that are very effective in doing this shared decision-making. And then talking about the Centers for Medicare and Medicaid Services, so they cover lung cancer screening, and they actually cover, all the screening that we'll be talking about today in this webinar. But for lung cancer screening using low-dose CT, the patient has to undergo a billable shared decision-making counseling visit in order for CMS to cover the screening. And so the shared decision-making visit has to include one or more patient decision aids. And those are things that, like, it could be a video, a relatively short video, like a 4 or 5 minute video, or a nice brochure pamphlet that explains the benefits and the risks of screening. And the patient also needs to be aware of the potential for diagnostic testing, invasive procedures to work up any potential findings identified on low-dose CT. As for follow-up, subsequent annual screenings, CMS does not require, it's optional, but CMS does not require shared decision-making after that first screening. So in terms of the goals, so the goal from Healthy People 2030 is very modest. So only 7.5% of eligible persons should receive lung cancer screening. That's their goal. And even with that modest goal, these data are relatively old, from 2015, but even that modest goal, we're not achieving. Only 4.5% have received the screening. And again, this is based on earlier task force recommendations. This is based on people with a 30-pack year smoking history, and who quit within the last 15 years. I should mention that in the World Trade Center Health Program, we do also track lung cancer screening, and we appear to be much better with lung cancer screening at many of the clinics that see our members. The rate of annual screening is 50%, 50% or higher. So much better than what you're seeing nationally. So thank you to all the clinicians who on this webinar who are helping to achieve those impressive results. And then the last cancer we'll talk about is colorectal cancer screening. And so colorectal cancer is the third most commonly cancer diagnosed in both men and women. And in men, it's the third leading cause of cancer death. In women, it's the fourth leading cause of cancer death. So in women, the third leading cause of cancer death is pancreatic cancer. And the median age of colorectal cancer diagnosis is 67 years. And so going back to this figure, so you just saw this figure for lung cancer. Now we're going to show the findings for colorectal cancer, which is the green line. And men are on the top, women are on the bottom. And you can see that the mortality began to decrease in men back in about 1985. In women, it looks like the decrease began in about 1950. So colorectal cancer screening really didn't commence until the 1980s, sometime in the 1980s. So maybe that's responsible for partly responsible for the decline of mortality in men, along with improved treatment for colorectal cancer, maybe reduction in risk factors. And then for women, I'm really not sure. There was no colorectal cancer screening going on in the 50s, so I'm not really sure why the trend for women began to decline in the 1950s. So in terms of colorectal cancer screening, the task force recommendation is to screen adults who are 45 to 75 years and who are at average risk for colorectal cancer. So this recommendation doesn't apply to people who are at increased risk, and those include people with a prior diagnosis of colorectal cancer, history of adenomatous polyps, history of inflammatory bowel disease, or a personal diagnosis or family history of genetic disorders like Lynch syndrome or familial adenomatous polyposis. So the thing to keep in mind with the task force recommendations is those recommendations are for primary care physicians. They're developed by primary care physicians and for primary care physicians. So when you get into these patients with an increased risk, you need somebody with expertise dealing with those types of patients to determine the frequency and the type of screening that's needed. So these task force recommendations are just for people who are at average risk of colorectal cancer. And so the task force has these 7 recommended testing modalities. The first 3 are stool tests that can be done either annually, or the third one, the stool DNA test with fecal immunochemical testing, can occur between 1 to 3 years based on the recommendation from the manufacturer. You've got colonoscopy recommended every 10 years, CT colonography every 5, which is basically a CT of the colon. Flexible sigmoidoscopy every 5 years, or if you combine flexible sigmoidoscopy with the FIT, you could do the flexible sigmoidoscopy every 10 years along with a FIT annually. So one question you might have is, okay, you got all these options, which one's the best? And the task force is unable to make that determination. The data just isn't there to show which is the best or which is the least. I mean, all of them are effective, all of them, for all of those modalities, the benefits exceed the risks. So, you can feel pretty confident in any of those. But which one is truly the best? More research needs to be done to compare the effectiveness of one versus the other. But in terms of detecting versus preventing colorectal cancer, so we talked about this with cervical cancer, and you see a similar phenomenon with colorectal cancer, in that the advantage of a colonoscopy and sigmoidoscopy is you can actually prevent the cancer. You can remove those polyps, those precancerous polyps, and by doing that, you're actually preventing the colorectal cancer from arising. So in contrast with the fecal test, you're just detecting the cancer at an early stage. You're not preventing it. And so you have this whole issue of prevention versus early detection. And so when you're seeing a patient and doing shared decision making, this is a item that should be discussed, is the advantages of colonoscopy versus the stool tests. And in the program, as I'll show also across the country, the most common colorectal cancer screening test, the most commonly used one, is the colonoscopy. So these are data from the Behavioral Risk Factor Surveillance System, BRFSS. These data are a little old. They're over a decade old. This is the most up-to-date data I could find for the US population, but you can see that in the US population, again, colonoscopy is the most common, by far the most common colorectal cancer screening test. FOBT is the fecal occult blood test. And again, in the World Trade Center Health Program, similar, the data is similar. Colonoscopy is the most commonly used colorectal cancer screening test. And in terms of compliance with the task force screening recommendations, so the 2030 recommendation, Healthy People 2030 recommendation is that at least 68% of eligible adults are up to date on their screening. And again, we're not quite achieving the goal based on National Health Interview Survey data. We're only at 59%. But again, we track this in the World Trade Center Health Program, and the findings in the World Trade Center Health Program is we're doing a lot better job. So many of the clinics that we work with, many of the clinical centers of excellence, the rate of members being up to date with colorectal cancer screening is like 75% or higher for many of the clinics. So again, we're doing a great job within the program. And so keep up the great work, our colleagues. Thank you. And then what to do if you do find an abnormality, find polyps on the colonoscopy. So there are recommendations for when members should return for follow-up, for a follow-up colonoscopy. Those are provided by the U.S. Multi-Society Task Force on Colorectal Cancer. And the follow-up interval is based on the type of polyp that was found and the number of polyps that were found. And again, once you start doing colonoscopies, more frequent colonoscopies, you're going into the diagnostic realm versus the screening realm. So the screening is just like every 10 years, but the program would cover this additional screening if you got these types of polyps, but it would be covered under the diagnostic plan. And then finally, looking at cancer diagnostics and treatment, I'm not an oncologist, so I basically just have this one slide. If you're interested in diagnostics and treatment, there's two organizations that provide high quality information, high quality clinical practice guidelines. One is the National Comprehensive Cancer Network. The other is the National Cancer Institute. I've got the websites listed on this page. The information at these websites is free of charge. So that's what I would recommend going to obtain information on diagnosis and treatment for cancer. And then in conclusion, so we talked about the epidemiologic studies of 9/11 exposed populations found elevated risk for some cancers. We talked about the task force recommending screening for cancer at 4 cancer sites, and that helpful diagnosis and treatment guidelines are available from the National Comprehensive Cancer Network and the National Cancer Institute. So that concludes my formal remarks, and I think we have a few minutes for questions, right, Anne?
Yes, thank you, Dr. Calvert, for the very informative presentation. I do have a couple of questions that already came in, but if anyone does have any questions, additional questions, feel free to put it in the question and answer at the bottom of your Zoom screen. So the first question I had is, you reported that the evidence for an association between 9/11 exposure and cancer is strongest for 4 cancers. However, all cancers are covered conditions. How did NIOSH decide to cover all cancers?
So as I mentioned in one of my slides, when the program was created when President Obama signed the legislation back in early 2011, cancer was not one of the conditions listed in that law that created our program. So cancer didn't begin to be covered until a year later. And what happened is we do add conditions. We do add to the list of covered conditions, and there's various ways that conditions are added to be covered by the program. And in this instance, a petition was submitted to add cancer. at least the evidence available for it wasn't convincing, but it was felt that we should get our advisory committee, our scientific and technical advisory committee, ask them for their recommendation and determine if the recommendation is based on a reasonable evidence and based on a reasonable basis. And so then the STAC, or the Scientific and Technical Advisory Committee, came back with a recommendation that we should cover many cancers. And the reason being that among the 9/11 agents that people were exposed to, there were at least 70 either known human carcinogens or suspected human carcinogens. And so the STAC looked at the cancers that those agents are known to increase the risk for. And so it was thought that the program should cover those cancers. And so the leadership of the program agreed with the STAC conclusion. And so the decision was made to cover most cancers. And then as I mentioned, 2013, prostate cancer was added, and uterine cancer was added in 2023, just last year. And so now we cover all cancers.
Thank you. I do have a question on cancer screenings during COVID. Have you seen a drop off of cancer screenings during the COVID pandemic?
We did, and I showed a figure on that, and I didn't mention it, but let me see if I could go back to it. Maybe I don't have that. But there has been, yeah, there has been a drop. Oh, here we go. So this slide here, I didn't mention this when I presented this slide. But so these are data for incidence, cancer incidence. This is females, but it also applies to males. You see these dots on the right. And so, oops, sorry. The authors of this paper didn't feel comfortable. So these dots are the incidents from the year 2020. And the incidence of cancer dropped that year, again, because fewer people were getting screened. And so as a result of that dramatic reduction in screening, the authors of this paper didn't want to draw a line to these dots because of just 2020 was the year that had the most dramatic impacts on access to medical treatment and access to cancer screening. So definitely there were reductions. We even saw that in our program. There were reductions in cancer screening. So does that answer the question, Ann?
I think so. We do have another question, but I want to leave you enough time to give the continuing education credits information in the next webinar. So if that person can email me, I'll put that.
I could probably, try to answer it in 1 minute.
Okay. Can you clarify the breast cancer information for Black women? Is it the social determinants that is placing them at higher risks?
So yeah, I mean, social determinants of health are basically according to the WHO, social determinants of health are the conditions under which people are born, grow, live, work, and age. And so for Black women, that population has been exposed to wealth disparities that arose, hundreds of years ago, just based on the structural racism that's existed in our country for at least a couple of centuries. So yeah, that structural racism and that longstanding disparities in wealth distribution impact on the social determinants of health. So they're all interrelated. So thanks for that.
Thank
So
you.
let me go to the how to get continuing education. So what you need to do is go to the CDC Train site and then look for this course, which the simplest way to find the course is just to type in WC 4740, and that's for the live course. You could also type in today's date with the WC 4740, but if you type in 4740, this is the only lecture that's going to pop up. And then you're going to need the course access code for the live lecture, which is the World Trade Center Health Program, WTCHP. So maybe, you know, I would recommend taking a screenshot here so you've got this information because it can be confusing. If you're looking at watching the recording of this webinar, you'll find the course using the number WD, not WC, but WD 4740. So then once you've identified the course, you'll indicate what type of continuing education credit that you want. Then you complete the course, which you've done, and then you'll see a Mark Completed button on the course page in Train, and click on that to move to the next step, which will be to take the post-tests. So the post-test consists of 4 questions. You need to get at least 3 of them right. You'll have 2 attempts to pass. And then once you do that, there'll be an evaluation. And then once you completed the evaluation and you passed the test, then you can get your certificate for the continuing education credits. Should mention that for the live lecture, you need to claim these credits within the next 30 days. But for the recording, or you know, if you wait more than 30 days, just go to the recording, because those credits are going to be available for up to 4 years. And then I want to announce our next lecture, our next best practices lecture, which will be on July 25th. So a couple months from now, and it's the title, Substance Use and Related Disorders in Trauma-Exposed Populations, Essentials for Screening and Intervention. It'll be given by 2 of our psychiatrists in the World Trade Center Health Program, Dr. Sandra Lowe, who's with the Mount Sinai Clinical Center of Excellence at the Icahn School of Medicine, and Dr. Frank Dowling. He's the medical director of Long Island Behavioral Medicine and is associate clinical professor of psychiatry at Stony Brook School of Medicine. So I hope you can join us for that webinar, and thanks for attending today. Really appreciate it. Goodbye.